you know, loss of weight, and you know, and failure to thrive, because that energy is being utilized just to use the respiratory muscles to try and clear the lungs. These will be the presenting features of pulmonary effects. So in terms of GI, I think I have already said there will be diarrhea and stomach distension due to being blocked, and poor nutritional absorption, poor absorption. So we're talking about people who you know, who fail to gain weight. In children, failure to thrive. In babies particularly. And you know, they will have a low BMI as well, body mass index, and they'll look like they have muscle wasting as well, due to low energy and low, you know, and inability to utilize nutrition properly. Another thing which I forgot to mention in terms of pulmonary, they will have an increase in AP, the anteroposterior surface of the chest, so they will have an increase that way. And then in terms of the pancreas, you know, there will be pancreatitis, and which I've already mentioned anyway, and you know, the dysregulation of insulin usage, and then so in terms of treatment, I think with GI, I'd already mentioned anyway, there will be rectal prolapse due to that impacted feces which are obstructed inside. And there will be high frequency of passing stools anywhere as well. And then in the summer months particularly, people with CF will perspire a lot, and again the perspiration has a lot of salt. So in terms of treatment is based on the affected organs. For example, in the lungs, because cystic fibrosis, people with cystic fibrosis will have infections with you know, pathogens such as Pseudomonas, which I've already mentioned. They will also be affected by things like Klebsiella pneumonia, the strep, the staph, I can never spell this word. They will also get colonized or infected with E. coli. I've forgotten one. I think it's a K. I'll need to recheck the name of this bacteria. And of course, Haemophilus influenza. So really, the treatment is based on antibiotics therapy to obviously get rid of the bacteria that are colonizing. And in terms of antibiotics that we give, if you were to think that a bacteria really is a cell that has a cytoplasm, and it has this is just the making of DNA and proteins. I don't know why I've done that. I've done it the other way around. Really, it has to be DNA copying and then coming in to become proteins. Down here I have my pen. So really, the therapies, the antibiotics that are given are things like penicillins, which are B-lactamase inhibitors. They will inhibit the peptoglycan, which is a cell wall component that gives the cell wall its structure and rigidity. So in destroying that, in inhibiting the synthesis of the peptoglycan, it means that the cell wall of the bacteria cannot be transcribed. Proteins for cell wall cannot be transcribed, and the bacteria will die. So these are the penicillins. We can also give things like the macrolides, which will bind the S50 subunit of ribosomes. The augmentins do similar, but binding the S30. So all of those just block protein synthesis, really. Other bacteria will destroy, stop the uncoiling of DNA and just destroy DNA. So really the aim is to just attack the bacteria as much as possible and just get rid of it, really. For example, the quinolines that are given, destroy, or we can also give bacteriostatics, which then just which do not really kill the bacteria, but just inhibit it and stop its multiplication. But then you obviously then need to use another antibiotic to kill it. So we can give antibiotics, but obviously with antibiotics we constantly have to think about resistance, particularly with things like community acquired pneumonia as well, and also just thinking about the pathogens that are in a community and the pathogens that are in that colonize CF patients. Things like Pseudomonas, which really have increased their resistance to the common antibiotics that we use. So the other thing that can be used are anti-inflammatories. I think I discussed anti-inflammatories in the COPD lecture. Anti-inflammatories to reduce the inflammation, things like corticosteroids, inhaled antibiotics, orals as well. So you can give as well bronchodilators, which I discussed, bronchodilators like the beta-2 receptor agonist. And then you can also give mucolytics, which assist in thinning down the mucus secretions so that they can then be coughed up and expelled. You then also need to replace the pancreatic enzymes, and usually in the UK, Creon is usually used, but there is a whole range of pancreatic enzymes that can be given. CF sufferers, well, people with CF will also need a high calorie nutrition that does not that does not limit fat intake. So there is no limit to fat intake. People with CF as well will need a replacement of all the fat soluble vitamins A, K, E, D, and they will also need a lot of physiotherapy. These are medical treatments, obviously, and then physiotherapy. In order to learn how to cough and how to, not to learn how to cough, but to cough effectively so that you can then get rid of the mucus that's blocked, cough effectively, and actually loosen up mucus. As well, there is also the positions, as in the positional the positions that have to be undertaken in order to facilitate the movement of secretions and mucus, so that they can be excreted. For example, say, if it's a right lung base, one has to lie in a particular way and have a physiotherapist loosening up those the airways, and then perhaps lying in a way based on the affected sections of the lungs, affected lobes of the lungs, to then help with the passage of the mucus and other secretions out of the lungs so that they can be coughed up. Another treatment modality really is exercise to build up muscles, because obviously these patients are people who use up a lot of energy. And then the complications of cystic fibrosis are things like pneumonias, people will also develop pulmonary hypertension and core pulmonary. And all of these, particularly, constant pneumonias and constant infections really lead to a lot of fibrosis because of the inflammation that occurs, and really just leads to deterioration of lung function. So, when we're talking about this, we're really, entering the end stage disease, which then leads to pulmonary failure, which really can then lead to, things like heart failure and death, really. People can, you know, have transplant, lung transplant. But again, with lung transplant, although it does improve, it will improve the quality of life, but it will not improve the duration. It will not elongate, you know, the lifespan. So, you know, that a balance has to be reached with the patient in terms of, you know, do they want to have a transplant and take a lot of immunosuppressants in the hope that, you know, because obviously all surgery is not guaranteed that it will be successful, in the hope that should it be successful, should the body accept that lung, there might be an improvement of their quality of life in terms of the CF, but, you know, there will be other effects of having a transplant, but you know, it won't prolong their lives in any way. So those are the, you know, discussions and the balance that has to be reached. And obviously when people are reaching this stage as well, again, it's similar to COPD in terms of the pathways that can be taken, about, you know, decisions that have to be made about what to do, really, because, you know, when someone is there is no recovery. You know, the next infection could be the last one, and all those decisions have to be made, and discussions have to be made. So I think I'll leave it there with cystic fibrosis. I think I've covered everything. That it is an autosomal recessive genetic disorder that mainly affects male children, Caucasians in particular, and it is due to a mutation of the cystic fibrosis transmembrane regulator gene, conductance regulator gene, that's found on the long arm of chromosome 7. And this mutation results in a number of defects, such as a degradation of the protein that encodes for the channel, because it actually encodes for the chlorine channel. So you can have, you know, absence, in the sense that it becomes degraded because of a deleted gene, causing misfolding of the protein, the deletion of the gene 508, causing the misfolding of the protein, which then causes the cell mechanism to just delete it. You can also have a truncated gene which misfunctions. You can also have a protein, a channel, that will not respond or utilize ATP hydrolysis and cyclic AMP. Or you could have a high turnover of the channel, or indeed low copies of that channel. And what that leads to is chlorine being retained intracellularly, and then forcing or attracting the sodium to then move from the extracellular surface to form sodium chloride. And again, when sodium moves, water follows, and then that really leads to blindings that have thick mucus that is not thinned down by any fluid, so that thick mucus sticks into airway passages, in particularly causing plaques that then block pathways and cause a lot of inflammation and infection to occur, leading to an obstructive picture that's seen initially. That obstructive picture becomes a restrictive picture as fibrosis continues. In the pancreas, similarly, there is autodigestion because of the blocked ducts. In the sweat glands, there's a lot of sodium chloride which is then perspired, and a lot of perspiration due to the amount of water that's in the sweat glands and ducts. And then in the GI, there will be rectal prolapse. Children will not pass the meconium, and there will be a lot of passing of hysteria, and just a lot of GI problems, really, including malnutrition, poor nutritional absorption because of a lack of all the pancreatic enzymes, and there will be poor absorption or absence of absorption of all the fat soluble vitamins, the GU as well, the infertility that happens in the males, and the cirrhosis in the liver as well due to blocked bile ducts, and pancreatitis as well will happen. And the treatment really is targeted at the affected organ in terms of if it's in the pulmonary system, antibiotics, based on the infection that's there, trying to control inflammation, and mucolytics, and indeed systematically nutritional support, replacement of those fat soluble vitamins, creon to replace the pancreatic enzymes, and really a lot of physiotherapy in order to allow to loosen up those secretions so that they can be expelled out of the body. So while I'm here, I will also talk about bronchiectasis, which is quite similar to cystic fibrosis, so it should be a very quick topic, I want to believe. So bronchiectasis is a disease of the bronchi. It is caused by inflammation, constant inflammation, leading to fibrosis and enlargement, or shall I say dilation, actually, because enlargement sounds a bit like things just become big, but what I actually mean is dilation of bronchi with thickened walls due to fibrosis. Thick fibrosed walls. So bronchiectasis, really, there are two types. 50% of people with bronchiectasis actually have cystic fibrosis, and then the remaining non-CF bronchiectasis. So, which is why really the pathogenesis is similar to CF. The only difference is that obviously these people will not have the genetic that's the underlying pathogen in CF. So in bronchiectasis, really what happens is inflammation due to, if it's cystic fibrosis, it is again based on everything that I've just talked about. And then, those thickened mucus causing an infection. And then infection causing inflammation. And really, what happens is that you will then have inflammation with activation of fibroblasts. I don't know if this pen actually works. And a lot of denaturing of the elastin in the bronchi, and fibroblasts will then lead to collagen deposition, and indeed fibrosis, And elastin will just destroy the elasticity, I want to say elastases will just destroy the elasticity, so there'll be reduced elasticity. So in terms of the underlying pathology, is quite similar to CF, so I'll not spend a lot of time talking about bronchiectasis, but the pathology will go from being confined to the bronchi, then move on to the bronchioles, and then really, affecting the small airways. So in terms of who gets bronchiectasis, actually it's a lot of females, and it's usually diagnosed by the symptoms which are similar to CF, as in productive cough. However, in here people have large amounts, copious amounts of mucus production, of sputum production, that is purulent, it has a lot of pus, and very smelly. And they will also have, because of that, the resident microbes, there will be that poor oral hygiene. Well, it's not really poor oral hygiene, but there is a smell that comes from the sinuses and the mouth, really. But then the most important thing is the amount of the sputum that is being produced, the mucus that is being produced. And during an infection, the mucus color becomes khaki, and at times it's yellowish green. So these are people who are really unwell, and they are short of breath, as in the CF people. They will have crackles. They will also more or less have similar presenting features to CF, except for if it's non-CF, they won't have, things to do with ions and loss of and issues with things like pancreas, and other GI symptoms that are associated with CF. And in terms of the CF, people with CF, well, if they have CF, they will have everything that I've talked about, or they might have a mild form of CF, because CF goes from mild to severe, and what I've talked about obviously is the most severe, but the grading can be mild to severe. So usually these people would have the milder form of CF. So it's the gold standard for diagnosis is CT, and usually all that's seen really are dilated bronchi and bronchioles, and that's what that confirms. It's highly specific for bronchiectasis when that is seen in CT. And the treatment is more or less similar in terms of managing, preventing infections, managing an infection when it occurs with antibiotics and mucolytics and anti-inflammatories. And really the progression, unfortunately, will be similar in terms of, fibrosis. It all starts as an obstructive disease. So fibrosis eventually leads to restrictive pattern, and which really eventually, because of the amount of fibrosis that's there is eventually respiratory failure, following obviously things like copulmonale. So the end stage disease, it's similar to cystic fibrosis. I'm just trying to think if I've missed anything in terms of bronchiectasis, but I don't think I have. And I quickly just want to, because I have mentioned respiratory failure so much, I just really want to talk about it ever so briefly. That respiratory failure, a lot of pulmonary conditions end in respiratory failure, or will present with some respiratory failure at some point. For example, even things like pneumonia will have acute respiratory failure. So, and obviously other chronic disorders like COPD will have a chronic picture of respiratory failure. So respiratory failure is in two types. There is type 1, which really is hypoxemia. And when we say hypoxemia, obviously we're talking about the partial pressure of oxygen in the arteries. So that will be less than 8, or indeed less than 60 millimeters per mercury. And type 1 respiratory failure is usually I ought to mention that while there is hypoxemia, the carbon dioxide arterial partial pressure of CO2 is normal or a low normal. So really the underlying pathology in type 1 respiratory failure is the hypoxemia. And in terms of conditions that lead to type 1 respiratory failure are all the acute pathologies. For example, pneumonia will cause acute respiratory distress syndrome in children, will cause acute exacerbation of asthma or COPD, will cause type 1 respiratory failure. And please note, this is acute. And sepsis. All the acute pathologies, really things which present with a acute respiratory distress, will cause type 1 respiratory failure. Type 2 respiratory failure is the treatment of type 1, I should just mention, is oxygen therapy the correction of the underlying pathology, what causes, because really this is a symptom of an underlying pathology. So treat the underlying pathology, correct the lack of oxygen, and it usually resolves. And obviously resuscitation, I should just say resuscitation with fluids and painkillers, just the resuscitation really. So type 2 is driven by hypercapnia, and there will be low oxygen as well. So there will be hypoxemia as well, but the driving force in type 2, we define it really